going my way to the rear. I wish to start by some thanks to thanking those who've contributed to putting the bill together and the work that's taken place, and enormous amount of work clearly as it's passed through the House of Keys. So I thank those. I'd like to thank those who contacted me, both spoken and in writing, to talk about the bill, and most of those who come to me have expressed concerns about the bill, but that perhaps reflects their awareness of my own situation in this. I recognise that there are valid arguments and indeed valid concerns on both sides of the assisted dying debate. Many such arguments we've heard in the House of Keys over these last 12 months. I respect the sincerity of those who believe it's time to change the law. I respect their genuine belief that they're seeking to make compassionate laws to reduce the agony faced by some people with a terminal illness. I understand the wish expressed by some people to have a choice about how and when they die. I also recognise the supremacy of the House of Keys in setting the direction, policy and law in the Isle of Man. Our role in Legislative Council is to scrutinise legislation that has successfully completed 3 readings in the Keys, to examine the principles, to identify weaknesses, to propose amendments, to improve clarity and to strengthen the legislation, and in due course return the bill to the Keys. Legislation on assisted dying, I would suggest, and this is what we've witnessed in the last 2 years, it is an incredibly complex, sensitive and controversial issue. The legalisation of assisted dying represents an extraordinary and enormous legal and social fault line or fracture. For centuries, and for good reason, it has been against the law to encourage or assist someone committing suicide. The legislation reaching Legislative Council today doesn't just change or amend the law, it completely reverses it. Actions that are expressly illegal today have become the government policies of the future. The Assisted Dying Bill 2023 had its first reading in the Keys at the end of June last year, but the briefings for Timble members began perhaps a year before that. My consideration, scrutiny, reflection on the evidence relating to the bill over almost 2 years, and particularly on the final bill before us today, leads me to believe that this law should not be changed. The existing law should not be changed, primarily because the bill simply does not provide adequate safeguards, and the need for safeguards was recognised by one of the previous speakers. I want to begin with a focus on the key issue or principle for me, the prevention of people being coerced to seek assisted dying. Life is special, human life is very special, but as humans we're also incredibly vulnerable, particularly as older people who can be targeted for financial exploitation. According to the UK Office of National Statistics, up to 1.5 million older adults per year in England alone have experienced some form of financial abuse. Sadly, according to the ONS, it is family members who are most likely people to financially exploit an elder. This is both a serious and a widespread issue. And of course, albeit the assisted dying bill, a person who's terminally ill can only be provided with such assistance in dying if, among other things, they have a clear and settled intention to end their own life, each voluntarily, without coercion or duress. Clause 6.7c requires 2 doctors, having separately examined the person asking for assisted dying, as well as the person's medical records, to be indicate that they are satisfied, that's the word, is satisfied, that the person's decision to end their own life has been reached voluntarily and without coercion or duress. I would expect that even the most ardent supporter of this bill would not wish anyone to be coerced into asking for assisted dying. I think we can take that as a starting assumption. I do not doubt that under the proposed legislation there would be a small number of terminally ill people who, without the slightest hesitation, would choose an assisted death and be grateful for it, and no doctor would doubt the voluntary nature of their decision. It would be absolutely obvious in everything they said and had done for a long time. But there is simply no evidence that it's possible for doctors in more general cases to identify with any certainty that coercion or duress has not been involved. And this is absolutely at the core of concerns over this legislation. Coercion and duress, manipulation, persuasion, psychological pressures, they can be within the family or within society. They can be obvious or subtle, they can be overt or devious. They can be genuinely caring, or they deceptively appear caring. We don't want you to have to face this death. Is that in support of assisted dying or just genuine concern? Or who knows? With private nursing home costs in the Isle of Man, and often exceeding £50,000 a year, it is not difficult to see why a vulnerable elderly person might feel under pressure as their hard-won savings are dwindling away. Victims may not realise that they're experiencing coercive control. They may even be in denial of it. In the US state of Oregon, the jurisdiction often cited as a model for British supporters of assisted dying, the most recent official survey showed that 46% of those who chose assisted dying mentioned their burden on family and caregivers as an end-of-life concern. Their burden on caregivers. Some people undoubtedly perceive they're a burden. Others may be unduly influenced or groomed to believe that they are a burden. They experience reactions from those supporting them which lead them to believe that they're a burden. The signing of the declaration by two doctors will not ensure that some individuals have not been pressured into a government-sponsored wrongful death. For me, this is first base in this bill going through. If safeguarding against coercion and duress is not in place, and probably not even possible, then the bill should not become law. In the deliberation and oral evidence sessions in the House of Keys over the last 12 months, there were some 130 references to the issue of coercion. Several expert witnesses expressed their concern regarding its identification. I'll run through a few of those. Dr. Duncan Jerry, a consultant geriatrician, said, "I would not know how to detect whether somebody making a decision based on coercion. Whether somebody is making a decision based on coercion. And I feel I've got more experience than many of my colleagues. Coercion is one of my massive fears about this because it can be so insidious and difficult to spot." Mr. Charles Foster, fellow of Exeter College, Oxford, a specialist in regulatory, medical and public law, he said one of the main concerns for legislators will be that of vulnerable constituents seeking assisted dying when they feel they are a burden. The evidence about that is completely unequivocal. Dr. Fiona Baker, local MP, GP, it is not possible to always establish coercion, especially if you don't know the patients and you do not know the family and you do not know everything that has gone on. That will be missed. Mistakes will be made. Baroness Finley, a doctor and professor of palliative care. Coercion, we know, is missed very often. Hourglass data shows that 1 in 6 people over the age of 65 have experienced some form of abuse, which will not be picked up by doctors. Doctors do not detect coercion. And sadly, I think many of us clinically have seen families that we thought were loving families until after the person has died, and then discovered things are different. Dr. David Randall, a consultant nephrologist at kidney expert at the Royal London Hospital, we do not have the skills for detecting coercion. Speaker after speaker has focused on this. Numerous MHKs themselves, they made their own concerns clear. Doctors are not trained to spot coercion. Another one, doctors and healthcare workers cannot be expected to identify coercion. But coercion is rarely witnessed. It's so subtle and a person's so often unaware that they are being manipulated. Someone else that it's very difficult to prove coercion. The assisted dying bill does not provide a safeguard against coercion, despite its recognition that there needs to be such a safeguard. There were hopes expressed in the Keys that some sort of advanced training would make doctors more aware of signs of coercion.
Honourable Member, I have a request to interject.
I'm so sorry. It's very interesting to hear everything you have to say. I just wondered if perhaps there had been some. I mean, we talk about no safeguards in relation to coercion, but not so long ago, in the last administration, we got through a domestic abuse piece of legislation, which I think covers some of the things that you're talking about there, relating to families and coercive behaviour, the definition of coercion itself, which is classed as okay, it might have a pattern of behaviour that may lead up to something to be identified, but that it would cause serious alarm or distress or have substantial adverse effect on the person's usual day or day-to-day activities. And it sort of outlines exactly how those people might be connected, so that they would be personally connected. So I wondered if you had had a look at the coercive criminal offences in relation to domestic abuse, because you say that the Office of National Statistics, some of that data perhaps can focus on family relationships.
To you, Mr Craine.
I think that we don't want to confuse what we're looking at here on a specific bill related to assisted dying with domestic abuse and various other things. They can be part of this, but perhaps to a greater extent in assisted dying, the abuse may be financial. But I think you raise the issue of the definition of coercion. I think if you look at 20 different dictionaries, you find 20 different definitions. But it's specifically in relation to this. I think I covered the wide range of this, and it's not necessarily familial, it may be social. The pressures that people feel, the coercions, and not necessarily by people who are going to benefit. The coercions may be, this is going to cost our health care, there may be social pressures that are put on people. But the idea that people are making entirely independent, arrived at by their own thinking and so on, positions can be in doubt. That's what I'm saying. Okay, thank you. There were hopes expressed in the keys that some sort of advanced training would make doctors more aware of signs of coercion, but Baroness Smith commented, having been a vice dean of a medical school myself, we have nothing on the curriculum that was specifically about how to detect coercion. I do not know of anywhere that has a specific module on how to detect coercion. I've made every effort here to ensure that I've not overstated the position on conversion, and I have deliberately not referred to the references by Lord Hunt in the House of Commons, which I thought go too far in stating some of the things that are there. But so I've deliberately not gone into that. I believe that accurate detection of coercion, as I've said, is probably not possible. How can doctors identify coercion when a person asking for assistance to die might not themselves recognise or accept that they have been manipulated? And I challenge members to ask themselves if they believe that doctors can detect coercion. If not, then whatever commitment you have to see this bill succeed, I want to ask if you're comfortable with that position. We all have a desire to ensure that any assisted dying bill introduced in the Isle of Man by the branches and the members of Tynwald has the necessary safeguards. If safeguarding against coercion is absent, then this bill fails to reach first base. I'd like to mention just several further principles that are more appropriately raised here than in causes stage, because they are broad principles rather than the details. The second principle I'd like to talk about is community. My experience and understanding of life tells me that I live in a community, a complex web of people and interrelationships in which we rely on each other. What I do and say affects others, what others do and say affects me. The cry of my death, my decision, it's no business of yours is not that simple. If assisted dying is made law, then it affects everyone. In particular, it affects people living with disabilities, with depression, suicidal thoughts, and so on. We heard a member of the Lords who came and spoke for us in a briefing and talked about how people say to her when they discover she's incontinent, say, if I was like that, I would have assisted dying. It devalues her life instantly, she talked about her feelings on that issue. In last year's report on suicides in the Isle of Man, recorded 8% of suicides were triggered by previous suicide. The impact of one person's actions on another is absolutely visible in everything I see. I've spoken to and heard from numerous people who say the lives of vulnerable people will be devalued. Some people have spoken to me about their concerns for the value of their own lives if this bill goes through. What is the balance between the people who will actually benefit from assisted dying and those who will feel damaged by it? The assisted dying bill is not only controversial, it is divisive. It will damage the island's community spirit, one of our greatest assets. It will drive a coaching horses to a suicide prevention strategy. Just within the last month, a man who feels suicidal spoke to me about that very issue, what the effect of this is on him. Once we have approved physician-aided suicide, although be it strictly in the context of a terminal illness which enables its designation as assisted dying, there will be no going back. I will deeply regret that social shift. Remember, this issue of community is secondary to the first base concern of coercion. The third principle relates to the idea that many advocates for assisted dying legislation already want it to go further. I recognise that the bill has some very clearly defined limitations. It's only for those over 18, diagnosed as terminally ill, who have capacity, settled intent to end their life. At the start of the journey, the bill was restricted to those expected to die within 6 months, but debating the keys and its clauses saw this replaced by a limit of 12 months. People with chronic illnesses that are not considered as terminal illnesses, such as Parkinson's disease, are seen by many of the UK lobby groups as a starting point for extension. Some groups have made it clear that they wish to see assisted dying legislation in the Isle of Man extended to cover involuntary suffering, even mental health. This has already happened, of course, in Canada. I have no doubt that if we pass this legislation, some of the lobby groups will quickly return to press for our act to be widened and extended. As far as they're concerned, this is only the start. This could easily become a slippery slope. Remember, this issue is secondary to the first base concern of coercion. A fourth principle of concern, the rejection by the medical profession. This bill upturns centuries of medical ethics and law. It actually empowers healthcare workers to hasten the death. The island's doctors have overwhelmingly rejected the proposed assisted dying law. 74% of those who responded to an Isle of Man Medical Society poll, out of 61% turnout, 177 members, said that they were against the changes. More than half of the respondents felt that any changes could have a negative effect on recruitment and retention. 34% of the respondents said they will consider leaving the Isle of Man if this legislation is introduced. Remember, this issue is secondary to the first base issue of coercion. Mandate. Fifth principle relates to mandate. There is no clear mandate for this bill. As the House of Keys election 2021, there were very few manifesto commitments to this legislation. When I stood twice for the House of Keys in 2011 and 2016, I visited a combined total of almost 4,000 houses in the constituency of Middle. Assisted dying was mentioned once. After all the consultations and surveys carried out on the island, some of which were actually sponsored by one of the biggest pressure groups for a change in our legislation, involved a degree of self-selection by respondents, meaning their results are not statistically significant. There is no mandate here for this bill. Some of the UK polls have raised concerns. In the Survation Dying Well survey of 2021, carried out on behalf of the all-party parliamentary group, it emerged that only 43% of respondents understood that assisted dying involved giving lethal drugs to terminally ill. 42% believed that assisted dying meant giving terminally ill people the right to stop life-prolonging treatment, which is practiced routinely in hospices. A further 10% thought it simply referred to hospice care. There is widespread misunderstanding of this, and surveys need to be looked at carefully. Remember, the mandate issue is secondary to the first issue of coercion. It's been suggested that assisted dying is not shortening life, but shortening death. I get that. But this is not the same as hospice. When the bill was introduced in the Keys, I went to visit Hospice Isle of Man, my first opportunity to go. I know some of you have visited too. This summer I also took an opportunity to discuss at some length and gather information on a hospice in the community program in the United States state of Minnesota, one of the majority of the US states where assisted dying is illegal. These are impressive resources. Hospice is not a decision to die, it's a decision to do what can still be done, a decision to improve the quality of life and the time remaining with the help of emotional support and preparation for the final months of life. They provide a comfort-based care plan for pain and symptom management, whilst offering considerable support for the families of people living through a period of terminal illness. In conclusion, I will be voting against the progression of the assisted dying bill beyond this principal stage today. I would urge members of the Legislative Council to focus on these principles. In particular, I would ask them to consider whether they believe it is possible for two doctors to look at the patient's medical records, interview the patient, and reach a reliable view on whether or not the patient's decision to request assisted dying has been made voluntarily without any coercion or duress. This is first base. This is the essential safeguard. I would urge members of the House of Keys to consider whether they still hold the same positions. And I recognise the comments made by my colleague, Mrs. Elsie, relating to what's happening in the United Kingdom, especially the House of Commons, and then the second reading of that coming up in late November will be important for us to see a number of things going forward. I welcome the comments on the need for an evidence stage. I know in the Keys debates you will find a reference from Mr Thomas, which is effectively a message to Legislative Council. The Legislative Council must follow through this. And it's over the issue of, which will perhaps be resolved when we get to the second reading of the House of Commons motion there. It relates to the issue of the people here, doctors, nurses, pharmacists who are regulated under general committees and authorities, the Medical Council and the Nursing and the Council of Pharmacists. They're regulated under those bodies. At the moment, the regulations will not allow them to participate in this. How much of a barrier that's going to be will only emerge once if in England is following the same route as this, then some of those regulations will have to change for the UK, but if they're not, this may be very difficult. But the main point I would just restate again, the key issue in this is the first base concern of coercion. Are we satisfied that it will be possible for a doctor to interview a patient and determine that there's no coercion taking place? Thank you, Mr. President.